Dr. Strickland, how do biomarker test results impact gastric cancer prognosis?
So biomarkers will directly guide our treatment decisions and how we can assemble the best treatment plan for our patient as an individual. And that will have direct ramifications for how well and for how long that therapy can work for. And so I would say that there's a direct correlation between the biomarker analysis to prognosis.
Dr. Strickland, how do biomarker test results impact gastric cancer treatment options?
So, for example, depending on the stage, if a patient has a stage 4 cancer, PD-L1 expression will guide our treatment decision whether to include immunotherapy, typically with a chemotherapy backbone, or not. And to say that a different way, if the expression is very low or absent, we know that that patient likely will not benefit from immunotherapy and could actually be harmed because there's some toxicity that comes with these treatments. That's one example, but similarly, for a HER2 positive patient, we will similarly assemble a treatment regimen with a targeted therapy that is included. And that usually leads to a better outcome than for patients that we can't include a targeted therapy and we're left relying on chemotherapy only.
Mm-hmm. Dr. Strickland, what questions should patients ask their healthcare team about testing and test results?
Because biomarker status is so critical for treatment decisions and then leading to outcomes and prognosis, I would encourage patients to ask their provider if all standard biomarkers have been obtained at the time of their diagnosis. And sometimes that answer is no, but they're working on it, and that's okay. But I would highly encourage patients to just ensure that standard biomarkers are being tested for and that they will directly guide the treatment recommendations.
Dr. Strickland, is there developing research or treatment news that gastric cancer patients should know about?
I think it's a very exciting time for the treatment of gastric cancer. Now, we still have a lot of work to do, and I don't want to minimize that. This is still a tough and can be aggressive cancer, and it's no time to let up. That being said, if we use immunotherapy as an example alone, there's been a flurry of new approvals for standard of care in the last 3 to 4 years. And our understanding is only increasing of how to select the right patients that will benefit, as well as how to avoid some of the toxicities. Beyond immunotherapy, there are new and emerging targets that we can design targeted therapy for. We don't yet have mainstream approvals for targets like Claudin 18.2, but this is a very exciting new target that I think will lead to an approval in the short future.